So welcome to another episode of Voices in Health and Wellness, where we have honest conversations with clinicians, founders and innovators who are challenging conventional healthcare and building new models of care. Today I'm joined by Dr Ryan Gannon, a family physician, co-founder of Blue Ocean Health and a strong advocate for direct primary care. Ryan has spent the last several years building a practice outside the traditional insurance system, creating a model that allows for deeper patient relationships, greater physician autonomy and a stronger focus on prevention and lifestyle medicine. Alongside his clinical work, Ryan is passionate about nutrition, strength training, and helping people take greater ownership of their health. Ryan, welcome to the show. Thank you so much for joining us today.
Thank you. Appreciate you having me on.
So if we could maybe start at the beginning, a bit about your journey, really. So what attracted you into medicine in the first place, and why did you choose family medicine?
Yeah, geez. So I'm definitely not someone who knew that medicine was going to be my path at a young age. Initially, I think it started because I had a very heavy interest in nutrition and exercise from a young age. Most of my background and when I was younger revolved around soccer. So anything that could give me an edge and make me a little better, a little quicker, a little stronger was that was my thing. And then I ended up playing throughout college, a little after college, and in college I met a professor and became very fond and interested in genetics. So I ended up doing a good amount of research there, and I think that's where my interest in the hard sciences really took off. After that, my path, the question was really, do I pursue something towards a graduate degree, maybe a PhD within biology or genetics itself? But I realized I really missed the people component. And I wanted something that combined that as well as the sciences, and medicine looked like it could be a good fit. So after that, I went as far as I could with soccer, and then ultimately decided to, pursue a path in medicine. Family medicine itself is, initially I was actually very much interested in psychiatry. And I'm very fascinated both with psychology and, holding deep conversations and really getting to know people on a much deeper level. But I think, the other aspect as well is in terms of independence and autonomy, I wanted to hang my own shingle. And in my mind, psychiatry was kind of the last or one of the few remaining fields of medicine that you could do that. In medical school, I met my current now business partner, Dr. Kavalak, and he ended up finding a group of docs who practice direct primary care. And we ended up getting introduced to a whole bunch of docs doing this throughout the U.S. A bit more. We're currently in Pennsylvania, but a bit more south and west. And it was when I got to know them that really, further encouraged me to look into family medicine. So it's sort of this combination of the people component, really to, getting to know people on a much deeper level, the model of care, and the ability to do my own thing. So I think it was kind of these three things that really pushed me towards this specific model and field in medicine.
Thank you. And for those that are the uninitiated, could you explain a little bit about what direct primary care actually is? I mean, it's something which is a bit of an alien concept in the UK, but it'd be really helpful if you can give us a sense of what it actually is, what the model is.
Yeah, absolutely. At its most basic level, it's a membership model in which patients, there's variations in themes, but for us specifically, our patients pay us a low, affordable monthly membership that gets us access to a primary care doc. And what that looks like is, we're frequently in contact with our patients through texts, emails, calls, video visits, and the membership itself covers any in-office visits as well. The reason for it is it allows us as the docs to have much more time with patients. So in the US currently, the average physician appointment is, roughly, depending on what you look at, 6 to 15 minutes. That's probably being generous. For our patients, we spend our shortest appointment is typically around half an hour. We'll take up to that as needed. When we get to initially meet someone and do a medical intake for that first visit, we'll spend up to an hour, sometimes longer. But it really brings in the convenience aspect. It's sort of crazy in my mind that when you look at, in 2026, all businesses generally have moved towards faster, better services. Medicine itself is a service, and it's a little archaic in, traditional systems that patients are still stuck waiting for appointments for hours on end. If they ever have a question about a lab result, they can't get a hold of their doctor. So the model is meant to really address the access component to a primary care doc.
Thank you for clarifying. That's really helpful. So at what point did you realize that the traditional insurance-based model wasn't really the way that you wanted to carry on? Or was it just the fact that you bumped into somebody who, had better ideas? I just want to get the kind of sense of that decision point.
In my training during residency, I think we all, as from a child, and as you get older, you get the experience of an outpatient practice in general, and it kind of becomes the norm and the expectation. And then both, personally having some family friends who worked as docs and I shadowed them, I got a little bit better of a feel before medical school. And then it wasn't until residency during my training that I felt more of the behind the scenes pressures that doctors face and what they go through that you don't necessarily see from the patient side. I knew just based on myself and personality that if I, were likely to have to practice in a typical outpatient setup, I would have lasted, probably a week, and then I just couldn't do it long term.
Thank you. So tell us a little bit about Blue Ocean Health today. What does it actually look like as a practice after 3.5 years? Just give us a sense of the operation, as it were.
Yeah, so we were going on actually this past July was our fourth year anniversary. It's been a both fun and interesting journey. You learn a lot about business in general. I mean, if you're a doc opening this type of practice up, you might as well have gotten your degree in a small business. But we're up to nearly 400 plus patients at this point. We still do, as we're growing, we still do some various jobs on the outside to make the practice work. And I would say we previously talked about direct primary care, what that looks like. To expand a little bit about that, currently, when I last checked, I think there's at least 2,500, maybe getting close to 3,000 practices like us in the country. So we're starting to see the expansion of primary care within the US, I think, diverge a little more between traditional outpatient medicine, direct primary care, and then towards the other extreme, more of a concierge type of level. I think we'll continue to see things split like that. And then the other aspect is employer-based plans, as employers are looking to cut down on insurance costs. So with the direct primary care, an interesting aspect is they all tend to have like a unique flavor to them, or style, you can say. It depends on the physician running it, their particular interests. Maybe they have some additional training. So some docs may focus more on specific demographics or populations or conditions. We're starting to see more specialists, whether it's cardiologists or OBGYN docs, open up similar style practices. I would say for us specifically, we do all the regular, bread and butter family medicine conditions. I would say where we take a really heavy focus is on lifestyle and preventative medicine, both because, with my background, I have a really large interest in patients' habits as a whole. That's something that, number one, you rarely discuss in medical school, but largely makes up the life of someone: their eating habits, their nutrition, their sleep, their understanding of their medical condition, what things should or should not be done with medicine. There's so much that surrounds just a medical visit that goes into it that you never get to focus about. But that's largely my interest. So for my patients who are interested, which is probably a majority, we really heavily review those things on the initial visit, and then periodically throughout the course of the year, we're in contact, in addition to doing, checking all the boxes from a primary care perspective.
Thank you. And what does the patient membership look like from a patient perspective? I mean, I think you've alluded to some of the things around sort of consultation lengths and everything, but if you look at the whole package, what does it look like on paper for a patient?
Like, what does it consist of, or
Yeah,
cost, or a little bit of all the above?
Hmm.
So when you most direct primary care practices fall within very similar price ranges. For us specifically, from 0 to 18. So from a newborn, just born, up to 18 years old is $50 per month. And then we do from 19 to 63 years old is 75 per month, and 64 years old and over is 100 per month. And the way you could think about it is it covers all means of access to us. So like I mentioned before, all aspects of communication, whether that's phone calls, texts, emails, or video visits, and then the in-office visits. So we don't have an additional per office visit fee or anything like that. So we largely structure it around, what a patient needs. Typically, that consists of the initial visit when we're really diving deep and getting to know someone. So up to an hour consultation. Depending on the person, sometimes they have something acute going on that we need to address a bit quickly. I'm seeing them within the week, or at a minimum, we're touching base by, text or a call. I have some patients who choose to utilize us purely because of the responsiveness. So maybe someone who is a higher level, someone within the corporate world, or a CEO who is very busy and they need someone who can respond by text or email, depending on if they're traveling and how to coordinate things like lab work, etc. So it's very much individualized to the person, their conditions that we're working on, or preferences, depending on what that looks like.
Thank you. It's really helpful. Trying to build an understanding of how this all works. So how does the physician-patient relationship change when you take insurance out of the equation? Once you've been doing this for a number of years now, I just wonder if it kind of changes the frame with the patients themselves.
Oh my goodness, yeah, in so many ways. I think a good example is when we started. So 4 years ago, in this past July, we had a handful of patients who followed us from our training. So we started maybe with a group of 5 to 10 patients, and I had previously taken care of a handful of these individuals who chose to continue their care with us, and I thought I knew them really well on paper. And then within the following weeks of when we started our direct primary care practice, I realized I didn't know them really at all. So the ability to actually sit down with someone and just have a conversation for an extended, uninterrupted period of time, it really changes the dynamic of your ability to get to know someone, and then also the level at which you can deliver medical care. And I'll use, like, maybe a good example would be anxiety, right? So we all know, if you're, PCP, we all have the various medical conditions. We can kind of run through this algorithm. We can plug in some numbers in a calculator. We can administer forms, and we can be evidence-based. But for me to sit down with someone, and if I have 6 to 15 minutes for someone who has anxiety, I have no idea of what's going on in their background life, their stressors, their sleep, their coping skills in general. What does their diet recently look like? Do they have other medical conditions? What's their understanding of anxiety as a whole? So you can have someone who medical therapy is absolutely indicated for someone with anxiety, versus someone else who really just needs a therapeutic relationship and to sit down and have a conversation with someone for 30 minutes. And then they're otherwise good. They don't need a medical therapy. That's someone who would do very well with therapy. That's just one, example that comes to mind, but it provides much more options because of your ability to longitudinally get to know someone over time.
Got it. I'm building this picture in my head of how it all works. I'm guessing the business model is absolutely key to get right. I mean, you've been doing this for a number of years now, so you must have a sense of the number of people that you need to have in the practice, the kind of the number of staff, how to make the membership work so that it actually covers everything that you do. How do you get that right? It must be a very, very difficult juggling act.
It's I think it's as complicated as you want to make it. I mean, on one level, you pull out the calculator and you calculate what would a reasonable comparable, income, or how profitable do you want to be, and then how many patients realistically can you safely or do you want to take care of. So I would say most people, I think I know myself very well, that when I look towards the end of what I want things to look like, if you start with that and then work backwards, you can design what, and at least gear things towards building that, right? So a general PCP in the US roughly carries, depending on what you look at, anywhere from a minimum of 1,000 to 2,000 patients up to 4,000 or 5,000 patients. An average DPC doc, depending on how they set it up, can carry, I've seen part-time, DPC docs have 100 to 150 patients. I've seen established, DPC providers who carry 800 to 900 or 1,000 patients each. That may be someone who's been operating a practice for 10 or 15 years and really knows those patients well. So I think when you start with that end structure in mind, and then a business is business, you always have to make the math work. It's less complicated than you would think. And we have a lot of docs or, residents in training who reach out and say, how do you do this? And my response is, you made it to medical school and residency. You could figure it out. The resources are out there. And we're very fortunate in that this has been in place for minimum 15 years by now. So a lot of the docs who have been doing this for a very long time have created very useful resources that it's a matter of creating your list, checking the boxes off, forming your LLC, making sure, what do you want your location to look like? Do you have the structure in place? You check that box. Making sure you got your patient contracts, everything HIPAA compliant. So we're fortunate in that when we started, all that was in place. But I would say from a business perspective, rent is your largest overhead, making sure you have that covered. And the beauty is you don't have to figure it all out at once. I think a lot of, what business comes down to is not having the fear, just starting, and then you figure those aspects out along the way.
And obviously you have been building this for a number of years, but what has been the biggest challenge in building the practice, maybe clinically, but also the business aspects as well? What have you been the key things that have kept you up at night along the way, and things that still keep you up at night?
The biggest thing by far in our area is just awareness. So we're in, in Pennsylvania, which I would say roughly the northeastern U.S., is densely the most medically, from a population perspective, like the options that patients have are numerous around here. We have very large health systems in place that patients automatically recognize, the name, they have a specific history that comes to mind. So our challenge is education from like a marketing and advertising perspective, and explaining the benefits of the model. A lot of times we get asked, well, if I have insurance, why would I go this particular route, or, variations along that theme. If you go a bit more west or south within the US, it's been established enough that patients, generally already know what they're signing up for. So it's easier from that perspective. I would say that's been our biggest hurdle that we've had to overcome in the years. And then, still continues to be the biggest hurdle, is you can never, as a small business, have enough people know who you are. And then outside of that, I would say it's probably all the things that generally come with business. There's never a guarantee. Patients, unfortunately, can come and go. We're fortunate that we have a very high retention rate, but patients move, or things happen, financial situations change. So just always making sure that the numbers work and make sense. But my view is there's no guarantees either way. There's a lot of docs who they go to work for a hospital system, and that hospital system's taken over or goes under, similar in the outpatient practice. So it's a matter of what you're comfortable with, the risk from either perspective.
Thank you. So, I mean, you said it's obviously growing, and there's popularity here. I think you said 2,000 or 3,000 practices in the country. So there's obviously a need for this, and there's an appetite for this. Where do you see it fitting into the future of American healthcare?
I can't predict the future, but I'm hopeful that it'll be one of the main, if not main ways that primary care is practiced. I'm very much for options, so I want patients to have as many options as are available. So if someone chooses or wants to purely go through an insurance model, then they can have that ability. I want options between DPC practices. I think, the saying that a rising tide raises all ships. I think competition is healthy and brings out the best within DPC practices, but also within the medical system. So I think if a patient has the option to choose a primary care doc, apart from just geographically, but someone who they believe that they could connect with on a much better level, or for a different reason, then I'm all for that.
Thank you. Lifestyle medicine. Where did your interest first come from? And also, how did your athletic background shape your perspective on health? Because obviously there's a lifestyle aspect to that as well. So I'm just curious.
Yeah, like I mentioned before, I think that's my main interest. So it all started from soccer at a young age, and from very early on, I would try all sorts of various diets and nutrition styles to see if that would help me. I got into weight training at a very young age, and to see if I improved my strength or speed, could I get an advantage over any competition. I would say my biggest shift has been as I've grown older. I don't play soccer anymore, but powerlifting has become my thing. So for those who don't know what that is, it's basically a competition with three main lifts: the squat, bench press, and deadlift. So you basically train to become as strong as you can, within a given weight class for those exercises. And it's both personally really fun for me because I love seeing the incremental progress that you can get over time. And the other reason that it's really fun too is because for patients who are interested, I can incorporate my knowledge from a nutrition and a training perspective into their lifestyle. I think there's few things that make me as happy as seeing our elderly population or older patients that we care for, and especially women, whether they're young or older, being in the gym trying to build their strength. I think we've come a pretty long ways in society to overcome a lot of the stigma that kind of has surrounded weightlifting in general. And as the science and the education is put more and more out there, I'm very hopeful that encompasses a large aspect of primary care. But a lot of that depends on the doc. A lot of docs, purely want to practice medicine, and that's understandable. But I would hope that they at least have the knowledge of, if they have a patient who's interested, they would know who to refer to in their community for, a patient that would benefit.
Thank you. And practically speaking, how are you incorporating these principles into patient care, particularly what you were just saying about the powerlifting? What does it look like to a patient in that kind of consultation?
So it depends. I mean, as part of my intake, and I'm getting to know someone very often, one of the first things we'll do is I'll have a patient record a week of, I basically call them our logs. So a week of their nutrition. They would not change anything. So I want to see exactly it is what they're doing at this current point in their life. So they're writing down, to the best of their ability, what does their nutrition and fluid intake consist of? If they are exercising, what does that consistently look like on a weekly basis? The other big one I do as well is sleep. So I created my own very in-depth, detailed sleep questionnaire, both to screen for sleep apnea, narcolepsy, and other common conditions, but also just to get an idea of, if I have this patient in front of me from a habit perspective, where do they sit? How does this relate to conditions that we know that they have? What are they at risk for, and how do we improve their health as a whole? And it's good in the sense that sometimes I have patients come to me and they'll say, doc, I don't care what it is, give me the best nutritious plan and workout plan and I'll do it. To my response, number one, there is no such thing. And number two, if you're someone who's never stepped foot in a gym, our first goal is to get you walking outside for 5 minutes consistently daily until we can progress you to a point that, number one, we got to make sure you actually enjoy and like what you're doing. And then number two, from a habit perspective, what can we build that's going to be incorporated into your life and have some benefit in the long term?
Thank you. I was going to ask you a little bit about physician burnout, and I just wanted to get your sense of whether you think it's an individual issue or a system issue, and has DPC improved your own well-being and satisfaction as a physician? I guess I might know the answer to that, but I prefer to hear it from you.
Yeah, I don't know. That's a loaded question. I suspect it's largely systemic, but obviously you have individuals who have a tolerance or ability to operate within that broken system. From the system perspective, I think the issue is that you can't. Most traditional outpatient practices, it's a volume game. So in order to be deemed successful, rather than being purely about the care of your patients, is how much can you see, how many patients can you treat over the course of a given day. And you'll always lose in that system or that game, because it's a defined end. You can't it fails very early on. And then not only that, it becomes dangerous for patients as well. DPC. So I have some friends that I think in a typical outpatient setting, a very busy day would be 30 to 40 patients. Obviously, if we're talking about like an urgent care or an ER, that's different. But on a DPC, I refer to them as touch points. So I may see 5 to 10 patients in an office setting, but it's very common to have a touch point with 5 to 10% of your patient population. So if that's a text or a call or sending an email about lab results, and then scheduling a future visit. So it reduces, in my opinion, it reduces burnout a lot by creating the space, not feeling rushed, not dealing with a lot of the headaches and the background noise that you would otherwise have to deal with in a traditional setting. But to answer your original question, that's tough. Largely systemic, I think, but doctors, I think, are notoriously also very good at grinding themselves into the ground. So some games we shouldn't be playing.
Fair. So what does a sustainable medical career look like to you with your new perspective and this new way of working?
What was the initial part?
Say, what does a sustainable medical career look like to you now? How do you view that?
Sustainable? I don't know if I would think of things as sustainable. I would say, what does the optimal, most enjoying career look like in the sense of personal satisfaction and then highest value that I can provide for patients? And for me personally, it's a mix on, we're not full as a practice. I don't know what that number would look like, but it would come before if I'm feeling strained where I can't spend the time with patients. Patients are waiting for us. We're not finishing on time. So when things start to resemble like a traditional outpatient setting, I know we're already past where I want to be. For me, it's the combination of I'm treating patients to the level that I both should and I know that I'm capable of. And then the other couple big components within medicine itself is I still have the ability and the time for personal learning. I'm someone who still very much keeps up with my own regular study schedule on a consistent basis, or listening to podcasts, or, reading things I'm interested in, or bringing more aspects of things like that to the clinic. And then the other big component, like any other doc, is, I have a life outside of this as well, whether it's at the gym or, being involved in my church or community. And I think that equation is a little different for everyone. You kind of have all those buckets, and you get to choose how much of each of them that you want to fill, but it would resemble something like that for me.
Thank you. What excites you most about the future of Blue Ocean Health? If you're thinking ahead for, say, the next year or so, where would you like Blue Ocean Health to be? Any particular ambitions or things you're looking out for?
Yeah, right now, I would say our season is growth. I would love for us to have our, a second location at some point. Do we bring on another doc or two? Currently, it's just Dr. Cavalack and myself, so we're fully capable of still, providing the services and, behind the scenes. But at some point, you bring on maybe a little bit of ancillary staff to free up a bit more clinic time. But I would say our more immediate term goal within the next year would be, an additional location and expanding our influence into the surrounding areas where we practice.
And if you had a magic wand and you could fix one thing in the practice overnight, what would that be? Or if you can't think of anything in your own practice, perhaps more widely in healthcare generally?
In our practice, it would be, I would love, the ability to implement what I would say is like higher level, it's not testing, but let's just say higher level tools within the practice more systematically. So a few examples of that are, we have a small percentage of patients who wear things like Whoop or the Aura Ring. So the ability to, at more large scale, systematically both offer that to patients, but be able to interpret and go through the data. I would love an in-office like VO2, ability to test VO2 max. I would love, we partner with a few companies for in-home sleep testing, but the ability to offer that more freely. So I'm always thinking, what are tools that would be like very high yield and a very high perceived benefit and an actual benefit that we could offer our patients as a whole. So I tend to think of things like it would look something like tools along those lines.
Amazing. I suppose the question is then, where does the line come where you're putting all these wonderful things in and it kind of breaks the model because they become expensive and it's difficult to make them fit within the membership plan? Or is there a way around that?
Yeah, that's something we always toy with back and forth. Initially, it's, I think, as you start to add additional ancillary services, it probably looks like an add-on fee. A VO2, the ability to administer a VO2 max is not something that we obviously, number one, would do for every patient. But number two, we would have to, cover the cost for that. Certain things within our practice, we automatically include in the membership, whether, if someone comes in, they need a steroid injection for their knee, it's going to be, in our minds, it's silly to charge the cost of for, a single injection. Other things, both for us, but generally you'll see pretty common across DPC practices, is most tend to have contracts with wholesale pharmaceutical distributors so they can serve as an in-house pharmacy. And for the top 50 to 100 plus, medications, if patients choose to go through us, some of them do, save a good amount of money there. Sometimes it pays for a portion, if not all, the membership. So there's a couple of things or commonalities that you see most DPC practices, but for us in particular, I think it comes from that nutrition and kind of the training background, I'm always teetering on the edge of a combination of like performance and medicine.
On that note, Ryan, I'd like to thank you so much for joining us. It's been such an interesting discussion. I think many healthcare professionals listening will really relate to your experience of wanting to practice medicine in a way that feels more aligned with why they went into the profession in the first place. It's been really interesting to hear about the DPC model. I certainly have a better understanding of it, and it's very interesting to hear your focus on lifestyle medicine and how you bring that into your practice. So thank you very much for joining us. It's been great.
Thanks for having me. I appreciate it.